So genital ulcers. So here, which are the diseases which can cause? There can be syphilis. Second is a herpes. Okay. Then these diseases are grouped together. That is syphilis, genital herpes, chancroid, and LGV. So when there is an ulcer, we should keep in mind four diseases: syphilis, herpes, chancroid, and LGV. Okay. So syphilis, it is a painless. Then herpes is a painful. Syphilis is a single ulcer. Herpes is a multiple ulcer. Here it is a clean base of the ulcer is very clean in syphilis, and test is by diagnosis by serology, and in pregnancy there is a risk to the fetus. While in herpes it is a painful ulcerative condition. There are multiple ulcer. Initially there will be vesicles. It will form ulcers. PCR is the test, and neonatal herpes can happen. Okay. So primary versus secondary syphilis, dark ground, so that we will discuss along with the syphilis. So second was a pelvic pain plus discharge. That is the PID cluster. This we have finished. That is chlamydia, Neisseria gonorrhoeae, mycoplasma. Okay, so this group already we have finished. Here NAT is the first line treatment. Okay, low threshold for PID treatment, and partner notification is to be done, and TOC especially with mycoplasma genitalium you have to do. Okay. So this chlamydia, gonorrhea, and mycoplasma genitalium, this we have finished. Okay.
Okay.
Next is a abnormal bleeding. Sometimes if the clinical presentation is in form of abnormal bleeding, what we are going to think? Again, we will think about the chlamydia, gonococcal, or trichomonas vaginalis. Trichomonas actually we have seen with the discharge, but if it is a postcoital bleeding or cervicitis, our differential diagnosis will be out of these three. Okay, so it may be trichomonas, it may be gonococcal, or it may be chlamydia. Cervical friability, always exclude pregnancy and malignancy, and screen for co-infection also. Now next presentation is in form of lymphadenopathy, and genital lesion may or may not be there. There may be ulcer with lymphadenopathy, or there may be only lymphadenopathy which is present. Okay, then what are the things which we will consider? Okay, genital infections with lymphadenopathy, always think about the LGV, syphilis, and chancroid. Okay, and also your genital herpes also. Okay, because herpes will also have lymphadenopathy, but there will be ulcer also. Okay, so syphilis, LGV, chancroid. So what are the points which we will differentiate whether it is a painful or painless? Then if it is a bubo formation, then we'll think about LGV or chancroid. And MSM population, generally it happens in most commonly with the MSM population. Okay. Okay, now we'll start with the genital herpes. Okay. So we begin with genital ulcer disease. So first we will be discussing about 2014 UK National Guideline for the Management of Anogenital Herpes. Okay. Now, there are different terminologies with respect to herpes. Okay, when there is a herpes infection, it is either initial primary infection, initial episode, or primary infection, or non-primary infection, or recurrent episode. Sometimes they can confuse in the SBA this. Okay, so initial infection, initial episode is actually the clinical presentation. Okay, first clinical episode due to HSV1 or HSV2. Okay, initial episode either by HSV1 or HSV2, that is called as initial episode. What is primary infection? So primary infection is the first HSV infection with no pre-existing antibodies to HSV1 or HSV2. When we are talking about the immunological testing, and if this happens in a patient without previous antibody to HSV1 or HSV2, we call it as a primary infection. Okay, while initial infection is the clinical episode. Here we are not discussing with respect to the immunological testing, while primary infection and non-primary infection is with respect to the immunological testing. If it is it is happening in a patient who does not have previous antibody to either HSV1 or HSV2, it is a primary. And non-primary, it is the first episode of HSV1 or HSV2 with pre-existing antibodies to either of the pre-existing antibodies to other type. Okay, that means the patient has got a first episode of HSV1, but he has got antibodies to other type. Okay, that is non-primary infection. Then recurrent episode, reactivation of the latent HSV1 or HSV2 after the latency. So these are the different terminologies which are there. Okay, so there are two types of viruses, HSV1 and HSV2. HSV1 is the most common single cause of genital herpes in the UK, and classically it is orolabial. Now this is the question which is asked in September 2021, I guess. Okay, the common cause of genital herpes in the UK, whether it is HSV1 or HSV2, it is HSV1. Okay, normally, traditionally, what we used to think, HSV1 causes lesions above the level of the vest, and HSV2 causes lesions below the level of the vest. But this recent guideline mentioned most common cause of genital herpes in the UK is HSV1. Okay.
Oh,
Then HSV2, historically it was common, and more frequent it is known for the recurrences. HSV2 is mainly known for the recurrences. Okay, it causes this genital infections only, HSV2, but recurrences are more common. But the out of these two, genital herpes will be more common with HSV1. Okay. Then
I just remembered it like this. HSV is one, so one infection. HSV2 is the recurrence. Maybe
Yeah,
two.
recurrence are known to correct. So
Yes.
acquisition is by sexual contact with either HSV1 or HSV2. Incubation period varies from 2 days to 2 weeks. Primary response is that only 30% will be symptomatic. So even if it is a primary infection, only 30% will be symptomatic. And the type of infection may be primary, non-primary, or it may be recurrent infection. Clinical expression may be symptomatic or asymptomatic. Virus becomes latent and goes into the sensory ganglia. There is a periodic reactivation throughout the life. Okay, and symptomatic lesions or asymptomatic viral shedding can also happen, and that is responsible for the recurrences. Okay, and it is mainly with the HSV2. Possible transmission is possible even without the lesions, and long-term course recurrence frequency declines with the time. So majority of the patient will be asymptomatic because only 30% are symptomatic. That is what we have discussed. So majority cases will be asymptomatic. The symptom may be local or systemic. Local will be painful ulcer, dysuria, vaginal or urethral discharge. And systemic such as fever, myalgia, rarely there can be systemic symptoms alone. Okay. Now what are the
Oh,
signs? There will be vesicles that will form ulcer. It may be genital, perianal, cervix, or rectum. Then lymphadenopathy will be there. It is in form of tender inguinal lymph nodes, usually bilateral in the first episode. Okay, so if you have a lymphadenopathy in genital herpes, it may be unilateral also, or it may be bilateral. But if it is a first infection, in that particular case, it may be generally bilateral. Okay. First infection lesions are usually bilateral. So even the lesions will be bilateral, lymphadenopathy will be also be bilateral. Okay, while if it is a recurrent, generally you will have the unilateral disease and maybe unilateral lymphadenopathy. Okay, and generally there will be one favored site, either right or left, whatever, and on that side there will be recurrence. Lymphadenitis seen in only 30% of cases. Dermatomal spread, recurrences limited to infected dermatome. There can be secondary infections leading to autonomic neuropathy that will lead to the urinary retention. Okay. There can be auto-inoculation also because of fingers or adjacent skin, and it can also lead to aseptic meningitis. So these are the complications which can happen. Then there are atypical genital herpes. Okay. So this is what we have seen. Vesicles followed by ulcer, that is the typical one. Okay, but sometimes without ulcer you can have either erythema, fissure, or erosion. That is the atypical genital herpes. Okay, so there are high rate of misdiagnosis in these patients. Only 20% are correctly diagnosed in some studies. Always consider HSV in atypical genital symptoms. So even if you do not have ulcer, don't think that there is no HSV. Still it can be HSV if it is only erythema or if it is only fissures, still it can be HSV. Okay. There can be herpes proctitis also. It is an important cause of proctitis, especially in MSM population. Higher prevalence in HIV positive MSM. HSV1 and HSV2 both are implicated. Only 32% have visible external anal ulcers. Okay. So absence of the ulcer does not rule out HSV. Okay. Still it can be HSV. Now coming to the virus detection. Specimen of choice will be the sap from the base of the lesion or rectal mucosa. The indication will be essential for the diagnosis, prognosis, and counseling. That is, when you are dealing with case, you have to diagnose this particular case and take the appropriate swab. MSM with proctitis, you have to take the rectal swab. And you have to do the typing, that is either HSV1 or HSV2 in all newly diagnosed cases. We should know which type of, because if we know HSV1 or HSV2, then we can comment about the recurrence also. Okay. The NAT PCR is the test of choice, preferred diagnostic method. It detects 11 to 71% more cases than the culture. So among the culture and the NAT, it is the NAT which is preferred. Okay, it has got high sensitivity and specificity. It is less stringent transport condition, and rapid results are available. Confirming testing is not required. Confirmatory, once NAT is positive, you say that the test is positive. Okay. Then viral culture will miss around 30% of the PCR positive cases, uh, and reduce yield with late presentation, mild recurrent disease, poor or storage conditions are not appropriate. The efficiency will be reduced. Okay. So serology, we have to use selectively. So the main test will be the NAT only. Okay. So key principle is that it detects the past infection. IgM is not reliable. Okay, so you will do the IgG testing, and IgG1 and IgG2. Okay, IgG1 for HSV1, IgG2 for HSV2. IgM testing is not reliable. Okay, so HSV2 antibodies will be for genital herpes. If it is a HSV1, it cannot distinguish whether it is a oral or genital. Okay, urine test is not appropriate. So type specific cases such
Sir,
as
why
IgG.
IgM is not reliable?
Uh, not very
IgM is not
sure.
reliable.
Yeah, they have mentioned this IgM is not reliable. Basically, it may be a persistent infection, like the primary infection itself, only 30% will be symptomatic. No, are you getting what I mean to say? IgM will be possible even if you do testing for the IgM. If the patient is symptomatic and the IgM positive, then only, but only 30% will be uh,
Symptomatic.
symptomatic. Are you getting what I mean to say? 70% will be
Yes, sir.
asymptomatic and
Yes.
may
Most
present
of
with
the
the
cases
recurrence,
are
and may
asymptomatic.
present with the
Yeah.
recurrence. So more appropriate will be go for IgG. That makes sense, no? Okay.
Okay, sir.
So urine test is not appropriate. Okay. Then coming to the indications for serology, recurrent genital disease of unknown cause, counseling in initial episode, pregnant women, asymptomatic partners, and discordant couples, or those who are planning pregnancy, you should do the serology in these patients. Limitations, there are false negative after infection, and poor positive values in low prevalence. So they have given one chart that if you are doing it in the STI population, if it is your STD clinic, it has got a high prevalence of infection. So the positive predictive value of the test will be high. Okay. But if you do it in the general population where the prevalence is 5%, only 50% cases it will be positive, there will be positive predictive value. So when you do the test in a low prevalence population, then you have to confirm with the repeat or different test. While if it is a high risk population, it has got a high positive predictive value. Okay, this is what they want to say. Then coming to the
So,
treat. Yeah.
in short,
Yeah.
I think NAT or PCR is the gold standard.
Correct. Correct.
And amongst the IgG 1 or 2, it is not IgM.
Yeah, correct, correct. That is the take home message from this up till now. Okay.
Yes, sir.
Then coming to the management. Okay. General measures such as saline bathing, then analgesia. Remember, it is a 5% lignocaine gel they have mentioned, not the 2%. What the guidelines is a 5% lignocaine gel or ointment, useful especially before micturition. Okay. Uh, Sensitivity is less common, so it is safe. Then antiviral treatment, you have to start within first 5 days. Okay, when there is an acute presentation, you will start in the first 5 days. Okay, so it is indicated
Okay.
if the onset is within less than or equal to 5 days, if there are new lesions which are forming, and if there are persistent systemic symptoms. Okay, so it will reduce the severity and duration. It does not alter the recurrence risk. Okay, but the severity and duration will be reduced, and it is the oral treatment which will be favored over the topical treatment. IV is given only when the oral is not tolerated. Okay.
Yes.
Now remember the drug, doses, and duration. Okay. You have to remember, please remember the drug, dose, and the duration. These are the three things we are going to remember. Okay. And we have to remember the alternative also. So what is the first line drug? It is a acyclovir, 400 milligram TDS, and the duration of the treatment is a 5 days. So genital herpes standard treatment is 5 days. Okay, standard treatment is 5 days, and acyclovir 400 milligram TDS. If we go for valacyclovir, it is 500 BD for 5 days. If it is acyclovir, but you are giving low dose, then give 5 times, but give for 5 days. Okay. And famciclovir 250 milligram TDS for 5 days. So remember here by duration. So if you get this particular question as a EMQ, so initial treatment in non-HIV patient positive, non-HIV population, it is a standard 5-day treatment. Okay. So select the option with 5 days. Then drug of choice will be acyclovir, and then look for 400 TDS. They may give 204 times, 203 times also as a confusing with a right 5 days duration. Okay. So you have to select appropriately. Okay. Then 500 BD for 5 days. Okay. So review at 5 days and extend if there are new lesions or systemic symptoms. So you may have to extend if there are clinically further this particular thing. Okay. So you will hospitalize if there is a urinary retention, meningism, there are severe constitutional symptom, and you will catheterize or you may consider suprapubic if there is a severe pain. Okay. Either catheterization or suprapubic if it is a severe pain, then suprapubic catheterization is also indicated. Okay. So recurrent genital herpes. Now what we have seen is the primary episode presentation, acute presentation, that treatment we have seen. Now coming to the recurrent. Okay. It is usually mild and self-limiting. Management is a patient-centered. Strategy may change over a period of time. Management option will be either supportive only or give episodic antivirals and suppressive therapy. Episodic means when there is a episode, then you treat with antiviral. Or the third option will be suppressive. That is a long-term therapy. Maybe for 1 year this therapy is given. Okay. So one, it is only supportive treatment you can give. Second, you treat with the episodic antiviral. Third, you will give suppressive therapy. Okay. So episodic antiviral therapy reduces duration by 1 to 2 days. Then no drug superiority. Then early patient initiated therapy is most effective, and short course, that is the first line. Here the duration of the dose is high, but the duration of the treatment is only 2 days. Okay. When there is a episodic antiviral therapy, so you treat for a shorter duration. Okay. So acyclovir 800 milligram TDS. There it was a 400 TDS for 5 days. Here it is 800 TDS for 2 days. Okay. So this is the episodic treatment. Okay. Then famciclovir 1 gram
but
BD.
if you calculate the dose of the drug, then in the episodic the amount is more. There it was 400 milligram TDS for 5 days. Here it is 800 milligram TDS. So per day amount is more.
Generally what I remember is these infections are generally milder. Okay. So milder infections. So the duration required is you need to tackle for the initial episode only, initial part only. So shorter duration, 2 to 3 days. Okay. This remains same TDS, but give high dose. Okay. So high dose with short duration, while the TDS will remain same. Okay. Famciclovir 1 gram BD for 1 day. Valacyclovir 500 BD for 3 days. Okay. So acyclovir is given only for 2 days. Now, if it is a suppressive therapy, what are the indications for suppressive therapy? If there is indication will be more than 6 recurrences per year, significant psychological distress, patient preference. Okay. What does it do? Suppressive therapy, it will reduce the frequency and severity. It is very safe for long term. Acyclovir has got a more than 20 years of data. There is no routine monitoring is required. And the drug of choice is 400 milligram BD. Okay. Here it is a 400 milligram BD. Okay. Or acyclovir 200 QDS you can give. Famciclovir 250 BD you can give. Valacyclovir 500 OD you can give. And stop after 1 year. Okay. So if there is a breakthrough, then you will increase the dose and stop after 1 year. So you have to treat this, what you can say, recurrences. Suppressive therapy is for 1 year. Okay. Now, if it is a asymptomatic viral shedding, which occurs in HSV1 and HSV2, it is more common with HSV2. Generally in the first year after the infection, frequent recurrences are known to happen. and majority of source of transmission reduced by antivirals and declines with the time. So how will you prevent the transmission? Avoid sex during the lesions and the prodrome. Then condoms will reduce the transmission by 50%. Antiviral will reduce the shedding by 80 to 90%. And a valacyclovir is also effective in reducing the transmission. Okay. So HSV2 decrease HSV2 acquisition in serodiscordant couples if these things are followed. Okay. So you have to counsel the patient. Diagnosis causes distress and reassurance is essential. So avoid alarmist term like it is incurable or it is a chronic. So we have to give the natural history, then transmission risk, mentioning there can be asymptomatic shedding, the role of the condom, role of antiviral we need to discuss, and most needed 1 to 2 sessions for counseling. Okay. So refer if there is a poor adjustment after 1 year. Now, genital herpes in pregnancy. Okay. So if it is a pregnancy and genital herpes, what is the specific things? So avoid transmission to seronegative pregnant partner. So condom use, especially in third trimester. Abstain during the recurrences and inform obstetric team only. So if they give you the treatment they ask you the treatment in a pregnant women, just don't look after the medical things. You also look for if any option has got a pharmacological plus non-pharmacological approach. Okay. So about condom in the third trimester, abstain during the recurrences, etc. So these options also we need to read carefully and look for the complete option. Okay. So genital herpes in HIV patients. Okay. So HIV patient, the difference is that it is more frequent, severe and atypical recurrence. Okay. Recurrent risk increases with low CD4 count and if the patient is not taking heart. Here the dose is high, 400 milligram 5 times a day. Normally we give 400 TDS. Here it is a 400 5 times a day and duration is for 7 to 10 days. Normal our duration was 5 days only. That is for non-HIV positive patient. Okay. But for HIV positive patients, 400 5 times a day, 7 to 10 days. Okay. Other valacyclovir 500 to 1 gram BD for 10 days. Famciclovir 250 to 500 TDS for 10 days. Okay. If it is a severe infection, we'll use IV acyclovir 5 to 10 milligram per kg body weight given IV 8 hourly. This should be continued for 2 to 7 days or until clinical improvement and followed by oral antiviral therapy to complete a minimum of 10 days total treatment until re-epithelialization. Okay. Recurrence of genital herpes in HIV, the treatment will be episodic or suppressive. The higher dose will be required and longer duration will be required. No role of HSV treatment to reduce the HIV transmission. Now, drug-resistant herpes. Okay, here Foscarnet, pseudophobia and topical. I don't think they will ask about this, but mainly what we have discussed, the primary treatment, episodic treatment, recurrence prevention, and HIV positive. These were the 4 important things here. Okay.